So Norman asked me to talk about, more the strain and tissue Doppler of this, but I'm going to be a bit more general. Our goals of functional imaging is, A, if we can discover an etiology like L-kappa that may be, the examples that are reversible or that are treatable. Obviously to look at ventricular volumes, ejection fraction. This is going to be important for prognosis, diastolic function, pulmonary artery pressures, AV valve regurgitation, so both mitral and tricuspid. What is the contralateral ventricular function, the right ventricle? This is going to be important for prognosis. Regional myocardial performance, desynchrony, which is a whole topic in itself and quite controversial on how to assess this, and pericardial effusion. So starting with dilated cardiomyopathy, if you look at the clinical predictors of death, I'll bring the slide to say that I'm going to be talking about strain rate and strain and tissue Doppler, but you can actually get all the information you need on prognosis from very simple things, and you start from the clinical exam, which is going to reflect echocardiography. And if you look at mitral regurgitation, which you can hear with the stethoscope, you've got a twice-fold risk of death. If there is ascites, which is going to reflect right ventricular dysfunction and diastolic properties, your relative risk is almost 8. So don't forget that clinical parameters are probably more important than all of the stuff I'm going to talk about in this condition. And in fact, you don't have to get very fancy, because people have shown that the cardiothoracic ratio on chest X-ray, and there are conflicting papers, but it makes sense that if you have cardiomegaly and you can just use the ratio of your heart to your chest diameter, those that died had no decrease over time in that ratio, while those that did better after time had an improvement in their cardiomegaly. That's chest X-ray. You don't need to be too fancy for that. And the same can be shown for heart rate as patients improve if you don't have masking by beta blockers and other factors. So indeed, cardiomegaly in this paper as well, but there are others that have shown that it's less clear. But nonetheless, if you have an improvement in your end diastolic dimension, you had a better outcome than if you didn't. Same goes for end systolic dimension, which will reflect more of what your contractility is. And you can use ejection fraction or shortening fraction as used over here. And again, simple things like endocardial fibroelastosis is a very important predictor, because that's going to give you an elevated filling pressure because the heart is less compliant, and that's a poor prognostic factor. Right ventricular function at presentation is important. You saw that ascites is important. These things link together, and this was true in multivariate analysis as well. I've already shown you the systolic to diastolic duration ratio. These are simple things that you can use. We have not proven that this corresponds with prognosis. We're working on that right now, but I'm sure it does, because any global parameter like ejection fraction, filling pressures, etc. correlates with prognosis. And I showed you that in this in dilated cardiomyopathy, it is elevated whether you measure mitral or tricuspid regurgitation more in cardiomyopathy patients than in controls. And this is true both in dilated cardiomyopathy and restrictive cardiomyopathy. And we studied, we meaning Norman and myself, because dilated cardiomyopathy is thought to be predominantly a disease of systolic dysfunction, which it's not, it's both. But if you have to look at a prototype, it's systolic dysfunction, whereas restrictive cardiomyopathy is thought to be a prototype of diastolic dysfunction, and the SD ratio is abnormal in both conditions. I'm going to skip over this for lack of time. There are reference values out there if you need them. Now, I think when we look at a heart like this, we don't need anything to tell us that there's dysfunction. You don't even need this echo. We could have probably done it on the clinical exam, as I showed you beforehand, and the clinical history. So, to look at abnormal tissue Doppler and strain is fine. I think there have to be specific indications, such as prognosis or risk stratification, or looking for desynchrony or specific stuff. But you certainly don't need a tissue Doppler to tell you that this left ventricle is abnormal. But just to say that the tissue Doppler will be decreased and of abnormal pattern, just for completion's sake. But you can get a little more fancy, and if you want to study, you know, which patients are going to recover better, and how does prognosis go, and what is the different patterns of dysfunction. If you look at a color tissue Doppler image and you place a region of interest, as I showed you before, from color tissue Doppler on here, the basal lateral wall and the basal septum, you can see that they again have different patterns of contraction, as I showed you before in the Al Kappa patient. So if you look at the lateral wall, it contracts, it starts contracting at the same time as the septum, but it ends earlier, and in fact it's starting to relax at a time when the septum is still contracting. You can understand from these patterns, and still you don't need that to diagnose dilated cardiomyopathy, but you can understand how this heart perpetuates its own dysfunction by continuing to fight against itself in a way that one wall contracts while the other relaxes, increasing regional wall stress, increasing myocardial oxygen consumption, and worsening the dysfunction. And so the enlargement in itself can contribute to these the heterogeneity in wall stress, and the regional dysfunction can perpetuate that in itself. Tissue Doppler has also been very helpful in adult paradigms, and this, as Norman stressed, works less well in children, and we're looking into that systematically. But in adult paradigms, works for a number of etiology. In fact, it's become, in the guidelines of the American Heart Association, of the American Society of Echo, it's become, as I said to you in the first lecture, central in the paradigm of how you grade diastolic dysfunction by the septal and lateral E prime wave, and how you look at filling pressures with the E2 over E prime ratio. And I'm not going to spend a lot of time because we did that in the first lecture on the first session 2 days ago. But be cautious, because in children, I think that children don't follow the paradigm that you see in adults. We hardly see patterns of pure delayed relaxation in kids. You do see it in hypertrophic cardiomyopathy, sometimes in other conditions with secondary hypertrophy, but as a rule, we don't see this classic marching through delayed relaxation, pseudo-normalization, restriction, irreversible restriction, etc. We usually see mixed patterns of disease, but you can use the E over E prime to evaluate filling pressures, as shown by Sheriff Negru. And again, it's a global thing because it tells you filling pressures, and so it's a global thing. The E over E prime in many papers corresponds with prognosis. So it's useful, and I'll show you in pediatrics it's useful as well. What about strain imaging in dilated cardiomyopathy? Well, again, you certainly don't need strain imaging to tell you that it's a dilated cardiomyopathy. And if you do a global longitudinal strain, those that had a very decreased strain, this is very abnormal, -7, versus those that had above -7 did more poorly. Not a big surprise. I could translate that into ejection fraction and tell you the same thing. But it just shows you that the reduced deformation or contraction of the heart will affect the prognosis. I've studied radial strain and other strains to show that there's a link between the amount of strain that the heart can generate in each segment, and it connects to the timing of the generation of that strain in each segment. And this links the synchrony to the actual function. You can see that strain, radial strain, and you can do this on longitudinal strain as well, is markedly decreased in dilated cardiomyopathy, but there's still a link with the time of development of that strain. And so we've looked at systolic dysynchrony in dilated cardiomyopathy, and it's present in kids. There's far less work on CRT, but this is thought to be a group that doesn't respond as well to CRT as other groups, and I won't get into that now. It's a separate topic. But we've also looked at diastolic dysynchrony and shown that perhaps this didn't reach statistical significance, but it's a small group of patients. And if you look at the actual Kaplan-Meier curves in terms of transplant-free survival, if you had diastolic dysynchrony, you did less well. So perhaps this contributes to those elevated filling pressures and why patients do poorly. So it's another aspect of dysfunction that perhaps we can start using these newer techniques to get a little bit more sophisticated beyond just its dilated cardiomyopathy. Colin McMahon, who's now in Dublin, and one of his colleagues is here, has done a lot of work in showing how tissue Doppler and the E to E prime ratio is important in prognosticating. you can see that in dilated cardiomyopathy, both the mitral and tricuspid tissue velocities in diastole, the E wave over here, as well as systole, obviously, are decreased. So what I want to say in this table is, A, it's not a disease of systole alone, it's a disease of systole and diastole, and it's not a disease of the left ventricle alone, it's a disease of the heart. If you have a left ventricle that's not functioning well and a right ventricle that's not functioning well, your prognosis is not good, as I'll show you in the next slides. So again, those that reached a primary endpoint, and this is death, transplant, hospitalization, that reached an endpoint had lower tissue velocities than those patients with dilated cardiomyopathy that didn't reach an endpoint. And again, the right ventricular parameters were also different. If you look at what actually came out significantly different, global parameters, as I said to you, such as ejection fraction, left ventricular dimensions, and the myocardial performance index were different between the groups that reached or didn't reach an outcome. But again, look at this, the RV-TE index and the tricuspid lateral annulus E prime diastolic velocity were important. So please look at the right ventricle as well, because that's going to determine your outcome. And here tissue Doppler will be helpful, because often you can eyeball the right ventricle, but if you put a tissue Doppler on the lateral tricuspid annulus, you can quantify this much better. And it should correlate with TAPSE as well, although I don't know of any studies that have specifically looked in children at that. So again, this is just showing the univariate analysis. Now, moving from dilated cardiomyopathy to non-compaction, I'm not going to show you a lot on non-compaction. I think it's a disease that we still don't know by echo how to diagnose well, when it is and when it isn't. Some cases are clear, some cases it's not clear. Norman has done work in this area with Raj Pan in prognostication. But just 2 slides on this, and we could have done a whole session on non-compaction. But you can see that there are going to be tissue Doppler abnormalities, again work from Colin, and he actually showed that again it was related to prognosis. This is non-compaction that I skipped over. Again, the tissue Doppler was related to prognosis. So once you've established that it is non-compaction, you can use the tissue Doppler to prognosticate, because this disease is much more complex in terms of the clinical course and variability than just dilated cardiomyopathy. So just moving on to hypertrophic cardiomyopathy, you've heard what it is. And what's interesting in echo is now that we're working out which genes are prevalent, and these are the 2 most prevalent genes in most areas in the world, the beta-myosin heavy chain proteins and the myosin binding protein C, you actually get different patterns of hypertrophy that then have an implication for your prognosis. So this, which is one of the most common patterns, is associated with these genes. And it's gene positive in almost 80%. There have been recent guidelines that have come out this year, a multitask guidelines with people from nuclear medicine, MRI, and echo. And there's no doubt that echo is the central imaging modality in hypertrophic cardiomyopathy for many of the things that you need to work out in hypertrophic cardiomyopathy. And I won't go through the whole list, so Norman went through a lot of them when he showed the images, but echo can answer most of those questions. And septal thickness, as pointed out before, for years has been known to be a prognostic factor, so you don't need to go to strain imaging for that. We use bicycle echo to evoke outflow gradients in patients that don't have an outflow gradient at rest. If you have an outflow gradient at rest, you don't need to provoke it, but this is one way we do it. We don't do it pharmacologically anymore as often. We use bicycle. That's been a change in practice. And if they have very high gradients, those treating them will start treatment usually. But I think what strain has shown us in this disease, as we learn more about the regional patterns in the disease, we have learned more about these abnormalities. This is bicycle echo, and I'll get into that in a moment, but if you just look at the resting longitudinal strain in this patient, here are the curves, here are the color-coded strain. Look at the basal septum over here. You can see that it isn't turning bright red. You can see just with your eye, with the strain, that there's an abnormality there. You won't pick up that abnormality with your naked eye. So you can see, and this is very typical of hypertrophic cardiomyopathy, it's almost pathognomonic for a genetic hypertrophic cardiomyopathy. I won't say pathognomonic, but it's very typical. But what you can also see in the global strain, if you average these, is that this patient, Norman, as opposed to the other one, reduces the global strain from 16 to 13 or 14 instead of increasing the strain. So this regional abnormality does not correct itself with the provocation of exercise, and it stays low, and overall the heart doesn't compensate for that regional abnormality. Now you can see these regional abnormalities with tissue Doppler as well. Here's the septum. You can see this reversed E-A prime ratio over here, but I wanted to show that it's not restricted just to this area. Again, the right ventricle can show abnormal patterns. I'm not sure why these occur exactly in terms of the mechanism. It doesn't look hypertrophied. And you can also use the E over E prime to assess filling pressures. But in hypertrophic cardiomyopathy, you've got to be careful. Because it's such a heterogeneous disease and because areas are affected differently, what you measure at the basal septum in terms of your E prime or the lateral wall may not reflect your global filling pressure, because that region may be abnormal, and then you're trying to assess a global index from a tissue Doppler index. So it's difficult to use in this disease, but still, again, Collins' work, who's studied all of these cardiomyopathies in the same way, showed that a decreased E and an increased E to E prime ratio does predict outcome in children. So if we're going to use tissue Doppler, this is one of the reasons why we're going to use it, and it is important. But there's probably better ways if you have this regional heterogeneity, and one of the ways that has become more accepted, I think, and is growing in practice, although not always routine in pediatric labs yet, is to measure left atrial volumes, which you can do very easily by echo using either the area length method or the Simpson's method. And Ben Idem's group, Shaji Menon, has shown that it correlates with the grading of diastolic dysfunction, and other adult groups, this group is from Naples here in Italy, has shown that in adults, left atrial volume corresponds with outcomes. And that's true almost in any disease you look at, because the left atrial volume reflects your filling pressures again. So I would prefer, rather than use the E to E prime ratio, to use an LA volume, because it's a more general index and not a regional index. There are patients who have mixed patterns. Here's a patient diagnosed with hypertrophic cardiomyopathy with an increased mass and wall thickness, but clearly has a dilated left atrium. If you look at the systolic function over here just by eyeball, I have to stop that, sorry. Anyway, it was normal, okay, it looked normal, but if you look at the tissue Doppler and the Doppler patterns, you can see this is your mitral inflow. You've got a high E to A ratio, you've got a very short deceleration time. This is typical of a restrictive pattern rather than a hypertrophic relaxation abnormality. If you look at the tissue Doppler, it's very abnormal with low velocities. And here's the color M mode that Norman mentioned. Instead of being very delayed, it's very sharp in this patient, although in restriction, you usually should get a slow color M mode. This type of physiology is important to diagnose using any technique, so regular Doppler, tissue Doppler, whatever, because it carries a markedly worse prognosis, because again, you have high filling pressures and worse prognosis. I'm going to skip over this, but all this is saying is that tissue Dopplers can be used to detect early abnormalities at a time when you can't see them with the naked eye yet. And it can possibly differentiate between hypertensive cardiomyopathy and hypertrophic cardiomyopathy when you may have a family history. It's not clear if that individual carries the gene. There may be high blood pressures or borderline blood pressures, and there's work to show that you can use tissue Doppler for this disease. This is a strain in cardiomyopathy. I've already shown you this. Look again at this very abnormal basal deformation in the longitudinal strain. There's correlation with late gadolinium enhancement on MRI. And this is important because the most thick segments at that basal septum are also the most abnormal, as I showed you in terms of strain, but also have post-systolic contraction, as Javier Ganami showed. And this correlates with the abnormalities in strain, both the post-systolic contraction and the reduction in strain correlated with VT. So patients that had VT had more deformation abnormalities. So there's a mechanical, electrical association of some type here, or a combined markers, should we say. Some people, like Bart Beingens, has stressed that you can actually diagnose different diseases using the strain patterns. I'm not brave enough for that, but there's certainly typical patterns of deformation. These hearts aren't, the etiology isn't only different, but different regions in the heart are affected differently. I'm going to skip this just to say that we are investigating now the correlation between genes and modifier genes and how the heart contracts in different regions. So just to summarize the hypertrophic cardiomyopathy, you want to look at the severity of hypertrophy, septal thickness, the pattern of hypertrophy, whether it involves just the septum or other parts of the heart as well. Don't miss apical hypertrophy, which can be missed if you're not looking for it. You want to look at outflow tract obstruction and systolic anterior motion at rest and with provocation of some type if it isn't there. Mitral regurgitation, which Norman showed, diastolic dysfunction, and connected to that, your pulmonary artery pressures. In hypertrophic cardiomyopathy, it doesn't happen in terms of percentages in many patients, perhaps less than 5%. But when you have frank systolic dysfunction, that's a bad sign. That's what we call a burnt out phase of hypertrophic cardiomyopathy. And I think tissue Doppler and deformation imaging have given us additional insights and are very useful. They're not in those multimodality guidelines at present. Thank you.
For you, and you feel like me to